Okay, it's 12:04. I think we'll make a start. Very grateful for everyone joining us this morning. We're talking specifically about cancer today, but if you caught some of that conversation between myself and David, we're going to lead this into some work later in the years around inequalities, try and link the two together. But today specifically, we're very lucky to have three fantastic speakers. We've got a group of people who've dialed in to listen. Some clinical, some policy, some the sort of data geek side like myself and Paul, who are interested in collaborating around the use of cancer data in the open. Three great speakers. I'm going to start by asking Mike Richards to describe the opportunity. We'll keep it positive, Mike. Describe the opportunity, and then I'm going to go to David, who's a surgeon in the hospital trust that I work in, and then we'll come to Martelie, who probably more than the four of us works more closely with cancer data. So over to you to start with, Mike.
Thanks very much, and good afternoon, everybody. For those that don't know me, I was for many years a National Cancer Director, but more recently I've been working with NHS England on diagnostic services, and even more recently as chair of the National Screening Committee. So I suppose the brief summary of what I'm going to say today, for those who want to have a little snooze, is we've come a long way on cancer data, but very slowly. And we've got a lot further to go. The question is how, and that's what I want to get answers to today. So we've had cancer registration for more than 50 years in this country. And that effectively was recording incidence of cancer, the number of new patients with cancer, which was then linked subsequently to death data from the ONS. And it was largely serving a public health function. In other words, was lung cancer getting commoner or less commoner? What about melanoma and the link to exposure to sunlight? Those things. And in a way, it didn't matter if it was a couple of years out of date, because you could draw a trend line and you could say, well, melanoma is going up and it was this 2 years ago. We can predict what it is this year. Also, at that time, I'd sort of go back 20 years now, frankly, the quality of data, the incompleteness of data was there. There was one cancer registry in the country, in fact, it was the largest one, where 20% of the cancer patients were only picked up after the patient's death. And basically by getting the death data and then looking back and saying, whoops, we didn't get this one in life. But people didn't terribly mind at that point, because as I say, we were able to extrapolate. But from about 2000 onwards, I think we woke up to the fact that we needed to use cancer data to drive improvements in service delivery. In other words, it had an NHS function as well as a public health function. And that was the start of a drive to improve timeliness and completeness of cancer registry data. But it was also a time where we said, there's an awful lot of data that we don't have on cancer patients. The government had set new targets on waiting times, the 2-week wait, the 31-day wait, the 62-day target, but we had no way of measuring those. So we had to set up separate cancer waiting times monitoring data sets. It took us about 3 years to get those up and running. And mind you, that was better once we had got it than having to do the laborious audit, which we did back in 1997, of all patients who had been diagnosed in the month of October 1997. We had to go by hand, manually going to see how long they had waited to get to treatment. We also set up a cancer patient experience survey, again paper-based, but it gave us a lot of new information, and it was sufficiently large that we could really see how different trusts varied from each other in terms of who in terms of patient experience was doing a better job. We could also see which patients were waiting longest or going to the GP most times, and that varied by cancer type, perhaps not surprisingly. We'd set up at that time standards for how cancer services should be run, the improving outcomes guidance. So we realized we actually needed to have a data set that would review progress against those measures, whether people were actually being seen by a multidisciplinary team, whether there was a multidisciplinary team in different hospitals. chemotherapy was one of the slowest to get data on chemotherapy. We spend millions on chemotherapy. We were promised, and Mark, you may remember this, we were promised that we would have electronic prescribing by December 2006. It took us about a decade longer than that before we'd got it. And actually, that is a safety issue. A paper-based prescribing is less safe than electronic prescribing, which picks up some errors. Again, we needed radiotherapy data. We got that rather laboriously. The radiotherapy data we need is all in the machines in a radiotherapy department. It's how do we get it out of those machines and make use of it. We have made progress. And then with the second cancer strategy in 2007, we took further steps forward. We set up the National Cancer Intelligence Network. That was really to bring together all interested parties. But I suppose the biggest thing that we started doing then was linking data sets. And that allowed us to link screening data sets, cancer waiting times, cancer registry data, HES data. And that allowed us to actually to see for the first time how patients were coming to diagnosis. And I think it shocked us all when we discovered that almost a quarter of all patients were presenting as emergencies. But we hadn't known that before. Equally, people think that screening is the answer to everything, and most patients surely get diagnosed through screening. Well, actually, only about 6% of all cancer patients are diagnosed through screening. 94% present symptomatically. Now that, I believe, can be improved, and we can come back to that. Equally, we have over time seen that the proportion of all cancers diagnosed through the urgent pathway, the 2-week wait pathway, increased so that it's now well over 50%. And we set up another separate data set to look at imaging, CT scans and MRI scans. We also looked internationally, the International Cancer Benchmarking Partnership. That was able to show us not only that we were doing poorly in comparison with other developed countries, but that if we were able to match the best, we would avoid about 10,000 lives a year within 5 years of diagnosis. And I don't believe that's changed, because although our survival has gone on going up, we haven't narrowed the gap with other countries. And it also helped to demonstrate to us the importance of late diagnosis. But it also, that it's not just that, we don't always give patients optimal treatment. We've moved on from there, and the National Cancer Registration and Analysis Service, otherwise known as NCRAS, really has helped by getting multiple electronic feeds. It doesn't matter whether we're talking about waiting times, pathology, radiology, endoscopy, surgery, radiotherapy, chemotherapy. But importantly, one of the things that they have been able to do is give us information on stage, using an algorithm based on all of those different things to say attribute a stage to a patient. And that is what, the headline, the target at the moment for NHS England is that we should have 75% of patients diagnosed at stage 1 and 2 by 2028. Well, it's only since we've had staging, and we've only really had that reliably since about 2015. So what's the problem? If we've done all that, why should we be worrying? And is there further to go? Yes, there is. Timeliness. We still don't have data on the full effects of even the first wave of COVID at a national level. We don't have stage, what happened to stage. Now, I would draw the analogy that we seem to know about COVID, numbers of patients, hospitalizations, intensive care unit admissions, deaths, almost in real time. Now, I realize cancer is more complicated. It's multiple diseases and multiple things, but surely to goodness, if we can do that for COVID, why can't we do it for cancer? And the problem is that because it's a couple of years out of date, it's not dynamic. We don't know which patients at which hospital are not meeting the performance standards, which trusts, which tumour groups, which diagnostic step is it? So I think that if we really want to drive improvement, we need to know all about that. And then there are other things that really matter. We're not linking GP records with hospital records. So we don't know what happened to the patient before they came to hospital, nor do we always know what happened to the patient after they left hospital, which we could usefully know. So, for example, what is the survival of a patient who's developed recurrent breast cancer? Now, I talk to all my oncology colleagues and they say, Mike, it's vastly better than when you were an oncologist. And they're probably right. But can I actually prove that? Can they prove it? The answer is no. They can't because we haven't got that data. So I'm just going to conclude by saying, clearly, in terms of priorities, we do need earlier diagnosis and faster diagnosis. But to do that, we need to get the data, and we need the data as near real time as we possibly can. We've got an opportunity. Sajid Javid has announced a war on cancer. And I think this is our opportunity to say better data will help to drive improvement. But so what I want from all of you is help in how do we get there. Thank you very much. Thank you, Mike. Really helpful.
There's some comments in the chat. If anyone's got any questions, just sort of put your hand up or shout out, because I'm chairing, I can't see everyone all of the time. Just a chair's prerogative, a question from me, Mike.
Yeah.
One of the things that we observed during COVID was a very disturbing drop-off in 2-week wait referrals quickly. Do you think we're doing enough now to assure ourselves that we're getting back in touch with those people at risk as quickly as we could?
From what I have seen, and I may not be fully up to date, there was a huge drop-off in just about all cancer types. But it recovered at a different speed for different cancers. And so the slowest to recover was lung cancer referrals. And I think that's a worry. The urology referrals, which includes prostate, were also pretty slow. So I think what happened there, we did quite a lot of work looking at where the problem might lie. I think the patients simply weren't going to the GPs. If you looked at GP data, there was separate GP data, what I said earlier was it wasn't linked to the other cancer data, but patients with the relevant symptoms simply weren't seeking help. So I don't think it's a question of blaming the GPs for not sending the patients on, it's the patients weren't going there. I think largely that's come back. And in some cases, breast cancer, it has overshot, which is probably a good thing. I mean, I'm sure if I was in a breast clinic, I might not say that, but I mean, from a patient point of view, I think that's the case.
Yeah, no, that's our experience here. I think it's a concern not just in cancer. There's people who've probably had mild strokes, mild heart attacks, all sorts of things, and been sat at home during COVID. And as busy as it is, we just want to see them back as quickly as we can. Okay, thank you very much, Mike, for introducing. I'm going to go to David now. David is a surgeon at East Kent, where I work, specialising in maxillofacial surgery. Taz, I think we've got a video we're going to play, and then we'll take questions.
Thanks, Mark. If my internet connection gets unstable during questions, forgive me, but that's why I videoed myself in anticipation.
Okay. Yeah, you're loud and clear, but we'll do the video.
All right, I'll share my screen. Can everyone see the video?
It's just coming through.
Hello, my name is David Tighe. I'm a consultant surgeon. I'm speaking from East Kent Hospitals. Mark Farr has asked me to join your session today to talk about a collaboration I have with the University of Kent Computer Sciences Department. I'm the Deputy Clinical Lead of the National Audit Programme, and a lot of the work that I've done with our colleagues at the University of Kent over the last 5 years is now embedded in that National Quality Improvement Programme, which will be the centre of our talk today. So it's from both the Research and Innovation team at the East Kent Hospitals Trust and also the British Association of Oral and Maxillofacial Surgeons this year. I have no other conflict of interests to declare. What is maxillofacial surgery? Maxillofacial surgery is a discipline of head and neck. It's populated by people who have both medical and dental qualifications. I'm a subspecialist in head and neck cancer and reconstructive surgery. I look after maybe 50 patients requiring major head and neck surgery a year, but that's not all I do. The department I work with has 7 consultants. We all have a fairly busy skin cancer commitment, looking after patients with sun-induced cancers of the face. We look after people who are walking out of pubs and clubs of towns around Ashford with cheekbone fractures and jaw fractures, kids with funny shaped faces, deformities that can be corrected to improve their dental occlusion, and patients with dental pathology that need surgical management. The essence of the QOMS project was born of a conversation with those people in our disciplines with such specialist interests to choose metrics. A metric is a piece of information we consider worth measuring. Good metric selection allows you to start a quality improvement program, but it's not straight. Choosing a metric is not straightforward. You need to be really careful that what you're choosing to measure is actionable. It's possible to measure some very worthy things that you hope to measure but are impossible to actually pin down. The metrics need to be reproducible both over geography and over time. So what we can measure in East Kent should be measurable elsewhere in the country. The metrics need to be have enough shared agreement to be worth pursuing in prospective audits. The metrics need to be tightly linked to quality improvement. So surgeons need to know intuitively that as care improves, so metrics should improve with it, and vice versa. We don't expect all units to perform exactly the same, but where we do converge, there's probably not a lot of sense in wasting a lot of resource on measuring that. So choosing metrics where variation is expected is a good use of time and resource. We can get some baseline data from the medical literature. We also argued at the outset that metrics need to be able to be modelled. The cohort that a unit treats in South East England will be very different from the cohort that will present on a weekly basis through the A&E doors or the clinic rooms of Liverpool, Glasgow and Birmingham. Our patients have a wealth of complexity and comorbidities, lifestyle choices, including smoking and alcohol rates. And public health specialists will, present the variations in those data, some of which are linked to health inequalities, and that they have a bearing on how a patient responds to treatment offered. And if we're going to make comparisons between the quality of care delivered at Unit A versus Unit B, we need to be able to include a flavour of the complexities of the cohort that they treat. So we, over the years, and this is just a brief overview, have developed models that allow us to risk adjust our data when comparing length of hospital stay or complication rates or surgical clearance of cancer from the operative bed. That's surgical margin status calculator in head and neck oncology stream of our QOMS audit. In the reconstructive stream of the QOMS audit, we've got a random forest that accounts for complexity of care when analysing the rate of free flap success. Free flaps are a fundamental part of reconstructive surgery. They describe the process of transplanting different parts of the body to the head and neck in order to reconstruct form and function. Our unit's failure rate is 2%. That compares favourably with national and internationally published figures, which sort of hover around 5% failure rate. Skin cancer surgery should, when done well, have a very rare rate of needing reoperations, and our surgical margin calculator accounts for the complexity of the care delivered using a multitude of features such as the anatomical subside to the tumour, the size of the tumour representation, the depth and the level of invasion of the tumour, and whether the tumour has the biology to progress along nerves. These are the sort of things that we'll touch on later on in the talk. at the outset of the work in 2016, we were using traditional medical statistics and platforms such as R, but we've moved to exposing our data sets to machine learning platforms such as Weka or SkiLearn. Data sets are around 1,000 in size, although the skin cancer data set we'll touch on later was much larger. And the types of models that are proving their worth in this search for effective algorithms that capture the diversity of the case mix that we encounter in our clinics. But effective models are logistic, regression, scores, naive Bayes, classifiers, decision trees. Our complication model is a small neural network. We've used linear regression models to adjust for complexity of care when assessing length of hospital stay, and random forests, as I've already touched on, were used in the free flap success versus failure model. And the process to capturing that data and presenting it to our colleagues in the computer sciences department is laborious. It starts as a clinician audit. There's a lot of pre-processing of data to harmonize and clean it and seek out gross areas of missingness in data to try and maximize the utility of the data to the computer scientists. They will only build models on a subset of that data, maybe 60%, which we term the training set, before validating their processes on a 20% training validation set, and reporting only the score accuracy on the remaining subset of data called the testing set. There's some tuning of the models before finalizing them and publishing score performance. Once we know that we've got an adequate way of modeling for complexity of care, we can start to adjust the observed rates of, for example, complications or positive margin status with the probabilities derived from the case mix model. And in doing so, we can transform raw data to risk-adjusted data and present them in the form of histograms, funnel plots, or run charts. So by way of an example, this dense textual slide just hints at some of the complexity behind the skin cancer audit. The textual information on the right of the slide by the high risk, very high risk red column highlights that bigger tumours of over 40 millimeters in maximum dimension with thicknesses over 6 millimeters, invasion to subcutaneous fat or involving big nerves, point to a higher chance that the surgeon will not adequately remove the cancer at the first sitting. Other parts of the patient's story, such as there being immunosuppressed for heart, liver, lung, or kidney transplant, those patients having had radiotherapy at the operative site in the past, are all things that we know make our work more complex and more likely to be unsuccessful. That data for 3 hospitals has been collected retrospectively over 3 years. The data is consecutive. The data was filtered to be done by only maxillofacial teams within the histopathology narratives, and there was something like 250,000 lines of text when all 3 hospitals over 3 years had their histopathology reports combined. Within that histopathology report, you will find your gender and your age and the diagnostic details about the tumour, as well as the features that pertain to high risk for both basal cell carcinomas and squamous cell carcinomas. And after a process of moving data from narrative form to tabulated form, initially using a Python library terms, but spending a lot of time clinician checking that because of the huge variation and missingness that resulted from that first step. We got to a point where all pertinent specimens, BCC or SCC, were captured for all 3 centres, nearing 3,300 specimens in all. And the data set was managed by an MSc student, Simon Provost, at the University of Kent, where data was further cleaned, ready for machine learning in the 2 environments that we mentioned briefly earlier. And the automated nature of machine learning these days exposes the data set to over 150 algorithms, which we point to there in this overpopulated slide. The certain algorithms behave better with certain data sets and patterns of data. The automated part of this allows the winners or the champions to run to the surface, and then further hyperparameter setting and tuning and optimizing can be done by the data scientist. And the provisional results from models developed both for analysis of possible margin status for basal cell carcinoma and squamous cell carcinoma are shown. There's they come with their false negative and false positive predicted outcomes, and these models are not weak, but they're not particularly strong either, but they are adequate for the purposes of some level of risk adjustment when presenting positive margin rates center to center over time. And we've done that for the first time in this chart. We've compared Chichester, Eastbourne and East Kent raw positive margin rate versus the adjusted rate. By way of an example, East Kent was alarming in the sense that our margin rate was at over 25% and shown to be beyond the upper alarm limit, which represented 3 standard deviations from the inverted commas national mean. But once case mix adjustment was applied, accounting for age, maximum dimension, tumor thickness, perineal spread, you can see that the complexity of our cohorts meant that our work was more tricky. And once the adjusted rates are reported, our activity sits very close to the expected national benchmark. Another application of our algorithms is to a run chart here, tracking the free flat failure rates over time in our unit. As I mentioned, our rate of failure is around 2%. This window of time is from 2015 to 2020. You get small rewards, if you like, with an uptick of the slope for every flat success, and a heavy penalty for every flat failure. And there's a devastating fortnight in 2018 where 3 patients had flat failure rates sequentially. And that in a healthy quality assurance framework would trigger a departmental and even a hospital level clinical governance response. And we can talk about the background to that fortnight and what came of it after the talk. So quality assurance is all about choosing metrics, but you need to be aware when you can concentrate on a single measure that can become a flawed process. You have to be really careful about human tendency to game the system, to be somewhat cynical, to maybe upstage certain things which you know will change the model's behavior, or avoid care in certain instances which you suspect will be likely to distort your results unfairly. So there's a whole clinical governance architecture that's got to build out of this process, which is going to be new for our specialty and will make the next couple of years really meaningful. I'll wrap up that talk there. I hope that's been a nice insight into how a collaboration with the university data scientists can contribute to improvements in clinical care and the publication of that care. Thank you very much for giving me the time with you today.
Thank you, David. Really helpful. And thanks for taking the time to do that as a backup way of doing it. Just a question from me, and Anthony, you might want to come in. There's quite a lot in the chat here. I'm just interested in the spirit of these webinars, David, is about how you collaborate, because you could characterize a lot of what goes on in the NHS as there's a brilliant piece of work being done over there, unless it sort of gets nationally mandated, through some of the stuff that Mike used to do. I'm interested in how quickly how does the collaboration feel like it works for you? Is it, a couple of mates from medical school, or is it through a registry, or an accidental meeting, and how do we sort of spread that quicker, and what might we be able to do to help?
I think trying to persuade surgeons to collect data faithfully on the adverse events that happen in their unit was impossible when I was a trainee, so I just did it myself. And the numbers in those data sets are accumulated over many night shifts and weekends inputting data myself. I think in a funny roundabout way, surgeons want to be given the support and the kudos that comes with being, if you like, kite marked or badged as taking part in a big program. And I'd like, there's a bit of a stick with this as well, commissioners to advertise openly that they want to see that kite marking when commissioning services to units that are actively engaged in quality assurance programs, such as QOMS hopes to become. Collaboration's really difficult. It was just informal meetings with data scientists who bothered answering my emails. Obviously, the more work you do, the more credibility you gain, and people start to offer you mini grants for the next chunk of work, and things build. But in my experience, I haven't done what some much brighter colleagues of mine will do, and just flown at high speed into NIHR grants of hundreds of thousands or millions of pounds. It's much more grassroots than that at the moment.
Having the sort of ear of the health secretary, publishing in Sunday newspapers, it was a very bullish way of developing data sets. What's your sort of view on how we might mandate more data outside of the traditional sort of mortality, length of stay, readmission rate, into some of the stuff that David's talking about?
Was that aimed back at me? Because
it was, yes. Sorry, I think I muted inadvertently.
I think what we need to do is to demonstrate that how this is going to contribute to a war on cancer. Clearly, if it can contribute to achieving the 75% stage 1 and 2, which is already an aspiration, so much the better. But even if it isn't, if it's actually going to get better outcomes, well, I think we need to retain a clear idea of how is this data going to improve, help to drive improvements in outcomes. If we can do that, I think we can persuade them.
Yeah, I think so. We should all, well, the spirit of these again is that we'll all keep in touch. So if Mike's helpful to you, David, and vice versa, we'll all nag each other. Okay, I'm conscious of time, so I want Martelie, who probably works with data more often than David being in theatre and Mike doing what he does now. I'll hand over to you, Martelie, if I've pronounced that right. I hope that's okay.
Yes,
and I'll save a couple of minutes for Paul at the end. So over to you, Martelie. Thanks for joining us.
Thank you very much. I'm just going to switch it to full screen there, and they can just confirm for me that they can see that. That would be really helpful.
Yeah, all good.
Perfect, excellent. So now my name is Martelie Isaacs. I'm the Principal Data Analyst for the Surrey and Sussex Cancer Alliance. I started in April 2020 at the height of the pandemic from no background in cancer, so I had to learn pretty quickly what was going on. So what I'll do is I'll just talk you through what we do, and then some of the challenges and opportunities that we see with cancer data. So with the Cancer Alliance, we're one of 21 across the country, and it's about bringing together clinical and managerial leaders from across various different trusts and organisations. So what I've put up there is, for Surrey and Sussex, we cover 3 ICSs, 7 trusts, there's up to 14 different sites there. So a lot of different people that we are engaging with on a regular basis. And the purpose of the Cancer Alliance is around reducing variation and inequalities and really transforming the cancer pathway. So improving outcomes, improving survivorship, patients being involved in their care plans and having their wishes reflected, and throughout all of that, sharing best practice, innovation and learning between different trusts. You know, if you're waiting for 4 weeks for a diagnosis at one trust, but you're waiting 10 weeks at another, that's not the same experience across the region, and it's about identifying that variation. So some of the kind of work that I do is looking at the performance standards. So we talked there about the 28-day faster diagnosis standard, the 31-day timely treatment standard, the 62-day standard, and looking at that across the 7 trusts, the 15 different cancer types, looking at it by CCGs and STPs and scaling it up and scaling it down to understand where our position is, where those outliers and variation could be, and trying to drill down what could be the causes behind it. So it's taken us 2 years to get to what I would call vaguely business as normal. For the first year of COVID, we didn't really look at performance data at all. It wasn't really appropriate. We focused very much about any data we could get our hands on and the impact of the pandemic at the start. So the 2-week wait referrals, falling off the edge of a cliff, absolutely. They dropped to below 40% of baseline levels. Some of them recovered really quickly. Some of them took a very long time. Neurological is the key one there. It took a very long time. It was a national. Some patients presented through other routes, so an increased likelihood of presenting through A&E. And for example, for breast, we had this increase in GP referrals, but we had a lag in referrals from screening as the screening programs had a delay. So where we may have a surplus of referrals for breast, actually we've still got a shortfall in treatments because of that shortfall from screening. So it really did vary by area, by cancer type. And so sort of that will come in again later as well, how that has impacted us with the data. So for us to be able to do all those things that we want to do, we want to transform, we want to improve, we want to reduce variation. We need data to underpin that. We need to know where the variation is and where the areas of strain and challenge. And the data directs us and it helps us to prioritize our work streams. It comes in a number of different formats. We get PDFs, tables, spreadsheets, sometimes really clearly laid out, sometimes quite complicated. We get it from a number of different sources there, as you can see as well. So quite often what we're doing is we're seeing the same data, but in slightly different formats and spending a lot of time just making sure, have we already seen this before and does it tell us anything new for us to understand better? So for example, we could get a direct data set from a trust. NHS Digital is around the cancer waiting times pathway and milestones, the patient tracking lists. CADIAS is a national body cancer alliance data and evaluation and analysis service. They support the alliances with modelling, so much more advanced, large scale modelling and dashboards, but also advice. Then NHS England Improvement will be much more around the long-term NHS plan for early diagnosis and improved survival. Charities such as CR UK and Macmillan, and then Public Health England, which is around the NCRES that Mike had mentioned there, the outcomes data, survival data that we look at as well. So based on all of that, I thought I'll just quickly highlight some of the challenges that we face. This is certainly not me talking for all cancer alliances. This is sort of my experience for the last couple of years. The biggest bubble there is volume. There is a huge amount of data, and to try and understand the caveats and the restrictions and the granularity of each different data set is incredibly difficult and time consuming. A lot of time is spent on that. And then sort of in terms of guidance interpretation there, are we all counting the same thing? Am I counting the patients that were referred to your trust and you're counting the patients that were diagnosed at your trust and you're counting the patients that were treated at your trust? Very, very fine details that take a lot of time to try and establish. And that was something that was really difficult during COVID because data sets were set up quite rapidly. And as you've referred at the start, Mark, you know, with the COVID hospitalizations and COVID deaths, those metrics had little shifts as the data definitions got refined and the criteria was improved. And we've had the same. You sometimes have a 2-hour meeting to define one metric of a new data set that we're collecting to make sure absolutely it is consistent and everyone understands the data in the same way. So that takes a lot of resource just to make sure that we are all, and especially if the data is being summarized over and over and used for work streams, that you are absolutely certain what you think you're interpreting is correct. Around data quality and completeness, so staging data, Mike talked about as well, we know that stage of diagnosis is one of the main factors that determines outcomes for patients, but in 2019, the data's just been released. There was about 22% of missing stages, which means you can't fully say what the rate of stage 4 versus stage 1 is if you've got a chunk of missing data. And for our region, Surrey and Sussex, that was even higher. We were at 30%. That is an area that we are very challenged on. And so for me, it's the question I get asked most often: has stage of diagnosis changed with COVID? And I will not happily say yes or no. Huge chunk of incomplete data that could swing it one way or the other. Some cancer types are really incomplete. So prostate was 32% missing, but lung was only 16% missing. So we already can see there at the very least that we've got this huge amount of variation, not only regionally, but by cancer type. And that might not just be where the data is not being recorded. It may be that it needs to be recorded in multiple different places. It's that interoperability between the systems of your data being on one system and you needing the resource to pull the data across and sometimes copy and paste all of that data across. So that's an incredibly time-consuming bit for trusts as well. And then they're about data sharing agreements, the granularity of the data. So I mentioned the 2-week wait referrals. We know there's a shortfall in urology. We can see for our region some of the demographics associated with that. So the age and sex and deprivation, ethnicity, but we can't really drill deeper. And we are a very big area. We've got some pockets of high deprivation and a lot of areas with very little deprivation. And so we know that we've got some areas that we really need to focus on, but when you can't drill deeper into that data, because the data sharing agreements are notoriously complicated, that is very, very difficult at trying to inform these projects and these work streams that we want to do. And then with the interoperability, again, just how simple is it to get the data? Are you pulling it from multiple different systems? How quickly and easy that moves across? That is really varied. So an example that I've got there is 93% of patients that come in through the pathway may not have cancer. You're only diagnosing about 7%. That does vary by cancer type. If you've only got the resource to record the investigations for the ones that do have a cancer, because those are the ones that you're tracking ongoing, you're missing this huge amount of data on the ones that didn't have cancer that had investigations. And if you're want to improve that demand, we're missing, again, this data completeness, data quality, because of a lack of interoperability between the diagnostic system and the cancer system. That comes up again and again. I could probably talk about challenges for quite a while. I thought I'll move on to some of the opportunities. So for us, we feel very strongly it's about getting the basics right. More and more data comes out all the time, but actually, if we're going back to the basics, having sufficient resources to record the data in the system or to transfer it across from different systems, and thereby improving that interoperability would be key, so that your resources are freed up for tracking patients more and engaging to improve data definitions and quality along the way. Using the systems to its full functionality, so the cancer systems, we are lucky, all of our trusts use the same system, some say, but they all use it very differently. Some use automated features to track where the patient goes next. Some of them will run very complicated queries. Others will have to run audits regularly to push and to identify where those patients are. And then around data sharing. So some alliances have got a very good setup with their ICS where they've got a full data sharing agreement. The ICS is the data controller. They can view patient data to a really granular level, looking at that local population data, and therefore getting those actionable insights, being able to really dig into the data, whereas others, such as our alliance, we are stuck with aggregate counts only. We can see data in discrete groups, but we can't really look at the relationships between that. So nationally, I think there's a huge opportunity to work towards working for consistent data sharing agreements and trying to improve and simplify those processes. Notoriously, it can take up to 2 years for one area to set up a data sharing agreement. And then the next two, the patient engagement and the actionable insight, I think sort of fits together, because if we're talking about early diagnosis and early stage and prevention as a big part for the cancer pathway, it's about engaging patients right from the outset and using data to do that. So if we've got these actionable insights where we're looking at cancer data and non-cancer data together and trying to see what are the drivers for a patient pathway, what are the key things that improves outcome. So for example, for certain cancer types, it may be early diagnosis is the biggest driver, but for others, it could be that treatment variation. And so being able to dig into the data. So the example that I thought of here is, for example, lung cancer, 80% potentially have ever smoked, whether they still are or have ever, and 20% haven't. And of the ones that are diagnosed with cancer, we can look at ever never smoked data on fingertips, like public portals, and we can look at diagnosed data from the cancer data, but actually linking those together, because that data is stored in the trust cancer data systems, looking at them together to see how does the ever never rates affect your stage, your outcome, your treatment choices, your aftercare, all of that is there's this huge amount of data that can be drilled into that trusts, and the people with the data don't always have the time to be able to step back and look at it at scale, whereas the alliance potentially could do. Looking at things like DNAs on outcomes, demographics, deprivation, ethnicity on outcomes as well, and linking all of this back to the patient at the outset to show them how their outcomes can be based on these insights, and they can be part of that decision-making process, which potentially can impact their entire pathway. So just a quick summary there, that we talk about that we're driven by data. We want to transform the pathway, and there are so many data sources, but there are limited resources, especially within trusts. And that is quite often where the most granular data is stored. So definitely opportunities for improved focus on data completeness as a key metric. We can't do ongoing tracking and change and look at the impact that we've had if the data is not complete. Improving your interoperability between different systems like appointing and diagnostics and pathology and cancer systems. Simplified and consistent data sharing agreements, and focusing on this cancer and non-cancer data together. And definitely think that these kinds of things will absolutely help alliances as the ones that pull and lead for the cancer in their area to meet those long-term goals of earlier diagnosis and improved outcomes for patients. So I'll pause there if anyone's got any questions. I can't see the chat.
It's good job, baby, Martelie, because it's ping, ping, ping. there's lots of questions in there.
Is there?
Some from me, some from some others. I'll start with a couple from me, and then one that David's alluded to. The first is kind of, I'm just interested in collaboration. So you sat there saying, it's very difficult and the data's a muddle and so on. Do you have a strong network of people doing what you're doing in other regions, and shared libraries for R code, and this is the best type of graphic to use to present this, and so do you feel like that? What's that like?
Yes, so I chair, we've got an analyst within every trust in our region, and I chair a monthly network meeting with all of them, so they can talk about the best ways to manage the data within the trusts and make sure that they are all interpreting new guidance in the same way. So we're very fortunate that we've got that network. And then there are a couple of national networks and forums as well, where we share and learn, which have really only recently started ramping up there. And then we've got sort of a national event where I've been asked, for example, to come and you show what you've been doing and what you're working on. You get really great ideas of what other areas are doing, but you also sometimes feel quite envious when you see that somebody is able to do really amazing analytical work because they've got access to this really rich granular data, or they might be hosted by the ICS. And so they've got very few barriers to the data.
Yeah, I don't know if you've done this yet, and it might be a question for David perhaps because he's closer to the data, but I mentioned in the chat earlier on about federated learning, and I wonder if people like you think that's, on the face of it, looks like a very strong opportunity, because the local very nuanced clinical data that you're alluding to, Martin, the big problem often is the IG, in that the trust can't easily pick that up and put it, where you would like it. And a lot of the stuff coming out of the Goldacre review is an argument for federated learning. So people like Paul at Open Innovations would host a model which they would just drop down into trusts or HSNs or so on. They'd receive no patient identifiable data, no data would move. The model would go down, the model would collaborate, the model would come up, the model would be refined. I just wonder sort of, what you thought of the opportunity around that, and then if that helps David with what you're doing, and I will save a couple of minutes for you, Paul, at the end. But is that something that's sort of come across your desk yet, Martelie?
Yeah, so something similar has come up a couple of times, where there's a discussion about something being set up behind trust firewalls, which then pulls all the data together, gives them all kinds of insights, and then takes perhaps even a non-identifiable aggregate counts back out to feed like a national benchmarking system. It is very difficult. It's about engagement, and as I say, the resource available. Trust experience have so far been that sometimes it gets set up and it doesn't get maintained, and then those same people end up having to do a lot more work to maintain a system that it can end up being quite complicated. So we are sort of trying to look at that kind of thing. We are trying to understand that better. I think that the COSD data, somebody's referencing there around Philip as well, with cancer weight in terms of COSD. The COSD data is phenomenal. There's a huge amount of data, but quite often you are limited to these discrete chunks that you can export at a time, as opposed to really following a patient all the way through. There's a data lag, which is understandable. It has to be fully validated. But I think if the data completeness was improved, I'd feel a lot more comfortable. So for example, there's a rapid cancer registration data set out, which is brilliant because you can really see the impact of route to diagnosis, where a patient typically would have come in through a GP route, but then a few months after the start of the pandemic, around June, July, you suddenly see the spike in A&E of patients that would have gone to their GP but ended up at A&E because they didn't present. That kind of data is so interesting because it's complete. It's that sort of staging data that trying to improve. That's what I mean in terms of getting the basics right. Before we even get with all this, the modeling, it's about just improving that interoperability and completeness, I think is for us. It comes up again and again.
Yeah. David, any comment on the federated learning? Because I'm just conscious that we've got good relationships across Ken, 4 big acutes.
Yeah.
We could try that.
Yeah. I would be really interested in doing a sort of regional approach to some of this work. I think people, it's just such a funny thing. It's like trying to invite people to something they know they should do. They kind of want to do. Everyone wants to do their job better for the patient care, but just trying to tell them it's not a waste of time. There's enough expertise and interest to make it, you know, a meaningful party. The thing I struggle with is this paradox. We work in a social model of health, the NHS, one of the biggest employers in the world. But actually, the disruption that comes from different bit part actors, different IT purchases, different products, some of which don't work and get dumped within a few years. It's just, you can't, I think it's really holding us back as a group of very, very similarly trained professionals. You know, I'll go to national meetings and talk to people all over the country, and we're doing the same thing. We can't prove that we're doing the same thing because the flow of data that might reflect that activity is just so disrupted, and we're not skilled to iron out the wrinkles.
Yeah. Well, I think that's a good challenge for myself and Paul. You know, the work we've done around domestic abuse, we're already in 2 other regions, and those regions are moving quicker because we did it first and we put a hand up and we were sort of brave about it. So it's a sort of challenge to how we do innovation. Paul, do you want to say a couple of words about the next session, because I'm conscious of time?
Yeah, so to David's point there, use the web. We need to cut across all of the different ways of doing that, and we'll just use the web to do that. Just a minute, someone's just shouting outside the door and just open.
Sorry, Mark, what do you think Paul means by use the web? Because
what he means
virtual platforms, the hospital data sets should be subscribed.
I'm back.
Yeah.
So if you look at the Open Innovations website, we ask people to do 3 things: to write story blogs about what they're doing, to write technical blogs about how they've done it, and then publish the code and the technical details of how they've done that, and where they can publish the data. And if we use the web, you manage to skirt around all of the internal decisions that have been made previously and some of the legacy stuff, and it allows us to move much quicker. So that the final part that Mark asked me to pick up on is that if you've managed to look at the Goldacre review, in there, there's basically it's a call to arms to share as much as you can and to do that. Bless you, Mark.
Sorry.
It's and if you use Twitter, I'd recommend just getting on Jess Morley's Twitter account and following her threads, and she's explained what the Goldacre review is all about and how you can get involved. NHS Digital are a sponsor of Open Innovations, and by linkage, Open Data Saves Lives. We're going to do something that the Goldacre review talks about, which is reproducible analytical pipelines, or RAPs. It's a concept. Lots of people have different views about it, but we're going to do a 2-day innovation session soon, probably after summer, where we're going to get everybody we can involved in working out what a wrap is, how they can apply it, and how we communicate that. And we're going to do it in the open, on the web, and get as many people to join in, so people can reach in when they're ready, not a meeting or a conference call or a Zoom call to do that. So please watch out for that, and hopefully we can start to show people how they can use the web to talk about all those things that you have mentioned there, David, that is the dark matter that slows us all down. So if you mention, I think what you're talking there is like the part in The Incredibles where Mr. Incredibles gets shot by the black blobs to stop him getting to Mrs. Incredible. So that's what we're all about, is trying to kill all that. And we'll be setting that up soon.
Okay, thank you, Paul. I'll talk to you more offline, David, as well. Mike, David, Martelie, really grateful for your time. We're quite early on in this. This is the first session we've done on cancer. We're lucky to get 3 such good speakers. We'll do more. We'll publish it all. We'll be back in touch. So thanks again, everyone. I'll just keep in touch and we'll let you know about the next session. Thanks all. Take care.
Thank you.